Garrett's having a few issues with his audio.
Okay.
Okay, Floyd and Rodney can let everyone else in now, then we can look at starting just a few minutes.
Hello, everyone. Good morning. Thank you for coming along to this important event, and to everyone joining us on YouTube as well. So these two faces on screen are two of the individuals who pretty much you're going to hear talking a lot today. We might bore you, but hopefully not. We'll entertain you more so. And of course, you will leave here with some good information. So the way we're going to kick this off is to have a conversation just to set the context. This is not my vision. This is the vision of the other person you see on screen here. We're going to have a conversation because it's something that's dear to him, and you will find out why shortly. So good morning, Pastor Wayne. How are you?
I'm well, Dr. Garrick. How are you?
I'm doing incredibly well.
Good,
So
good.
I just want to have a brief conversation with you just to put things into context for our audience. And I just want to go way, way back, and then we just bring it all the way up to date. So your dad was diagnosed with cancer, and sadly, he passed away from cancer. Is that right?
Yeah, that's right. In 2019, Dad passed away with a very short battle. Admitted to hospital, I think, not long after Christmas in 2019, and they diagnosed he had small cell carcinoma, and that he literally had 2-3 months at best to live. So yeah, he passed away sadly in 2019. And it wasn't until after I knew that he had prostate cancer, because they diagnosed that some time ago. And and they said they put him on watch and wait, as they do, or wait and see, I think is how they describe it. So he was on wait and see. What I didn't realize until after his passing and speaking with Mum was that my dad had actually been offered an operation, prostatectomy, quite some time ago for the prostate cancer. But my dad absolutely hated hospitals, hated needles. So for him, that just wasn't an option. I mean, he had to have hip surgery replacement, and that was a task. It took, I think, a year to convince him it was the right thing to do. So he didn't like it. So it wasn't until after his passing I realized that he had that offer. So yeah, it was a sad time, and in my heart of hearts, because the surgeons weren't sure of the primary cause of the small cell carcinoma, but I'm convinced it was prostate, because I look at all the symptoms. It's only now, latterly, looking at all the symptoms he had, pointed so much to prostate cancer, so much to prostate cancer. And I think it also speaks to the reluctance of men, especially Black men, to talk about it.
Absolutely. And it's a story I hear a lot, in that Black men pass away from prostate cancer, and it's only later on that their sons actually find out what was happening to them. Yeah. So it's very important that we're having this conversation. Thank you for being so transparent about that. And then not long after, your brother passed away from prostate cancer. Yeah,
2021. So in 2018, my brother was diagnosed with prostate cancer. And even at that stage, by the time he was diagnosed, it was already stage 4. It had already spread to his bones. Just backtracking a bit, I'd spoken to my brother on numerous occasions, Ian, go and get tested. And yes, I will, bro. Yes, I will, bro. And even when he was in severe pain, and I said, look, have you had your prostate checked? And he said, no. I said, go to the doctor now and get checked. He went, and that's when they discovered, obviously, the results. So he had a 3-year battle with prostate cancer and passed away in April of last year. So yeah, very, very tough time.
And I know yesterday would have been his birthday.
That's right. Yes, it would. Partly why we're doing this.
Absolutely. And so there's a family history there then, isn't there? Your dad, your brother, and of course, your risk of getting the disease increases because of that family history. Was that always something in the back of your mind? And we're going to come right up to your story, but how did that play on your mind?
Oh, wow. So, okay, let's go back a bit even before that. So the church we belong to, New Testament Church, we had a national secretary treasurer some years ago who was diagnosed with prostate cancer. And I remember him coming down and speaking to our local assembly and telling us what he'd gone through, etc. That really spoke to me. I said, wow. And literally from that point, I made sure I got tested every year. Something, I don't know, going back 2008, 2009, it was a long time ago. So I made sure that I got tested every single year. So for me, it was something I was aware of. Wasn't aware of all the symptoms, but certainly something that I was aware of. And I knew that getting a PSA test was very, very important as an indicator, not the only factor, but certainly an indicator. So getting tested all this time, so I was aware of it. Bang up to date now. So having been tested quite regularly, I noticed a slight increase in my PSA. So I'd go and I'd share my family history with my doctor. This was when my brother was diagnosed. I said, look, I'm really concerned. My brother's got stage 4, just been diagnosed, spread to his bones. I need to be checked. They checked me. My PSA was low, 1 point something. So I left feeling okay, fine. I'm okay. Did the digital rectal exam. Everything was, as far as I thought, was fine. But as time progressed, and if I go back, actually, I think going back to probably 2008, 2009, I had an issue with my water work. So I had stop-start urination. I was looking back at my medical records just to get the dates right, actually. And there's notes of when I went to my doctor to see, to talk to him, so look, I've got stop-start urination. Now, they put it down to prostatitis or maybe a swollen prostate, nothing to worry about. I was young. My PSA was 0 point something, so nothing to worry about. Went away happy again. So a few years, but that continued. And so I didn't really question it, because each time I go back to the doctors, they'd say, no, there's nothing wrong. They'd examine my prostate, nothing wrong with your prostate, et cetera, et cetera. And then obviously when my brother was diagnosed, it became more acute for me. So again, pushing for further explanations. And, you know, I was told, you're a fit young man, there's nothing wrong with you, you'll be fine, you'll be fine. But I remember after my brother's diagnosis, going to see the doctor, got a PSA test. My PSA had actually gone up from 1.4 to 1.9, and I think those are the figures. And he looked at me and said, yes, gone up, but it's still less than 3. You're relatively young. I wouldn't worry about it. Go and enjoy life. I said, yes, but my brother's been diagnosed. He said, doesn't always follow, but I would, you know, you're fine. But it wasn't coming up to date. It wasn't until, again, my brother diagnosed, and actually the start of last year. So the pandemic year, I missed being having a test. So last year, I went and got tested, but also I'd noticed a slight burning when I was urinating as well. So I went and got tested again. PSA had gone from 1.9 to 2.4. Again, the doctor said it's not a large increase. It is an increase. Let's do an examination of the prostate. They did. They couldn't feel anything. They examined me for a urine infection, thinking it could be urine infection while I was getting the burning sensation. And at this point, I said, look, I need further tests. I'm not happy with this. My brother's about to pass away. My dad's passed away. My granddad had prostate. My uncles have had prostate. There's a long history within my family. I was then, my doctor, we all credit to her. She said, look, okay, well, what I'll do, as you're insisting, I'll push it forward for a test on the basis of family history. She said, but I can't guarantee that they'll send you for an MRI because your PSA isn't at 3. So luckily literally within a week, the results came back. Yes, you need to go for an MRI. They want to see you. Had the MRI. Again, within less than a week, I think the results came back. There's something there. We need to have a look at it further. Again, went to have a biopsy. And even when I was going for the biopsy, I remember very well, the nurses said to me, what are you doing here? You're relatively young and your PSA is less than 3. There's nothing wrong with you. And I said, not for you to decide. Let's see what the results of the test were. So the results came back, and it was prostate cancer. So yeah,
it's incredible. It's incredible that you had to literally, it sounds like a fight to get properly checked out. But we'll pick up on that later. And the results came in.
Yeah.
And it was prostate cancer. What went through your mind?
Well, my wife was sat next to me as the results came in. And obviously the first thing that goes into my mind was my dad. My brother's passed away from it. So the first question I said to the doctor was, how long have I got? And he looked at me with a wry smile, and he showed me the X-ray. He showed me the MRI imagery. And he said, listen, it's as far as we can see, it's pushing up right against the edge of the prostate, but it's still contained within the prostate. So as far as we're concerned, we're going for a curative solution. In order to verify that, we need to do a PET scan. So we can send you off to Guildford to get a PET scan where they inject you with radioactive dye that shows your organs and relevant areas of your body to see if the cancer has spread anywhere. So I said, fine. But yes, in that moment, yes, you have anguish, and your mind does go to the fact that, you know, your brother's probably within the last few weeks of his life, your dad's gone. Does that mean it's going to be 3 for 3? So yeah, you do start thinking about that.
And just briefly, how did you have a conversation with your sons, or did you keep it a secret? No. Oh, listen, we constantly had a conversation, got back. In fact, so what we do as a family, when there's news of this magnitude to share, we normally say, right, everyone come around the house, and we sit around the table as a family, and we share the news every single time. So no, we came around, invited them around as soon as we got the news that evening, had them around, sat down and just talked them through what the prognosis was and what the outcomes were. And they're still young men, but I'm guessing you've already encouraged them to get tested.
Oh, absolutely.
When that time comes.
Absolutely. I even think some of them are on the call today. So yeah, absolutely.
Brilliant.
Absolutely.
It's a great place to start, a great context upon which to build. And I'm just going to hand over to you to really outline in some more details why we're here.
Sure. Thank you, Dr. Garrett. Appreciate that. Why are we here? So after the experience that I've had, it's a lived experience. And in sharing my news with people and with men, obviously, a lot of them are coming forward and saying, you know, they've either had prostate, or men I didn't even realize that had prostate cancer and had it successfully treated. But also men coming forward and saying, wow, I need to go and get checked. And you actually realize how many people don't talk about prostate cancer. You also realize how easily symptoms can be missed, and actually how we simply sit back, even though we may not, because only you know how your body is feeling. I knew what I was going through with my body at that time. Only you know how your body is feeling. So you try and relay that to the doctors, but obviously, you know, you have a 3-minute window with them to convince them actually something is wrong. So for me, this is about raising awareness. It's about saying to the men, you know what, if you feel the slightest thing is out of the ordinary, go and get it checked. There is absolutely no harm. Because also what I did find out, courtesy of Professor Eden, was that where my prostate cancer was, no amount of digital rectal examinations would have found it. It was on the other side of the prostate, which wouldn't have been identifiable from a prostate exam. It would have taken an MRI to actually tell that there's actually something there. So for me, it's actually knowing your body, and if something doesn't feel right, go and get it checked. So this today for me is about raising that awareness, and it's about encouraging men to go and get checked, arming them with the relevant information that they need, so they can go and be better informed and actually make those informed decisions themselves as well. So that's why we're here today. We've got some fantastic people who are going to be sharing their story. We've got some doctors and professors on the line. Let me quickly share my screen with you just to sort of highlight who we've got with us today. Yeah, so I've got Dr. Garrick. He's very kindly hosting the conference with me today, a very good friend. And he's a cancer conversion training lead at Imperial College in London, and the Institute of Cancer Research, honorary research fellow in viral oncology. He's also the senior pastor of a New Testament church called Reading, so he's going to be sharing with us. We've also got Professor Eden. He's a professor of urology at the University of Surrey. He's also consultant urologist at London Bridge Hospital, fellow of the Royal College of Surgeons. Now, what I didn't know about Professor Eden is how widely known he is. It's so great to have him with us, and he'll be on. He's got a clinic actually, so he's not joining us till about 11:45. But it's so good to have him, because we've also got Paul Simpson on the line, who's going to be sharing his experience, and also Andre Mars, another close friend of mine is actually in the US now. He actually. Professor Eden actually operated on all three of us, and I didn't actually realize. Andre called me yesterday and he said, I've just been checking through my notes, and Professor Eden was actually my consultant urologist as well, so a world-renowned consultant urologist. We've also got Dr. Jana McHugh, Dr. Eve McGregor, and Dr. Amal Singh, and you can see their bios there. They'll all be sharing with us in a short while. So we've got Andre Mars, Orville Thomas, and also Paul Simpson. And again, they're going to be sharing their experiences with us in a short while. So that's why we're here. Okay, so what I would do is encourage, everyone, if you can, turn on your cameras so we can see your faces. I'd also encourage you, please put your questions in the chat. Any questions you have for whether it be Dr. Garrick or any of the other doctors online, myself or any of the other advocacy ambassadors and patients, just put your questions in the chat and we will go through them as we go through today as well. Thank you very much.
Brilliant. Thank you so much for that. I'm going to set the context briefly, just by outlining to you what we mean when we talk about cancer. And I think there is a misconception that I often hear when we talk about cancer, especially in the Black community, where people will identify somebody that they know had a cancer, they were treated successfully for it, and then the question then is asked, is there a conspiracy here? Why do some people get cured of cancer and others don't? And I think that's based on the assumption that when we say cancer, it means every cancer. And so let me just sort of talk you through this, and then we will go further in our conversation this morning. So briefly, I want to share with you just a few ideas around cancer, how it starts, how it grows, how it spreads. And let me just put this into context. And I've got as a headline there, 100 million cells. And that is to speak to the fact that our bodies contain more than 100 million cells. And these are the basic building blocks, the subunits of which we are made up from anatomically. And there are around 226 different cell types, so lots and lots of cells. And just looking at the diagram, which is here on screen, some of those cells are highlighted in this graphic here. And if we take liver cells, for example, in the liver, cells in the liver are not just called liver cells, other cell types such as hepatocytes, cholangiocytes, endothelial cells, sinusoidal cells. So there are many different types of cell types there as well. And same in other organs in the body as well. So there are lots of different cell types. And usually we have just about the right number of each cell type because cell growth and cell reproduction is a very tightly controlled process. It's incredibly regulated. However, when the process is controlling this cell regulation of the growth regulation of cells, something goes wrong and these cells start to grow too much. As a result, they form a tumor or a lump. It is that tumor where cancer starts, and that is due often to changes in the DNA, which is the genetic material of the cell. So that is just to set some context. So when we ask the question, what is cancer? Again, to speak back to what I was talking about earlier, this misinformation in our communities sometimes that cancer is just cancer. It doesn't matter where it is, if it's in the kidney, if it's in the brain. No, actually, cancer is the name that we give to a group of diseases. They can be in specific parts of the body where cells are growing or reproducing uncontrollably. And these cells can further grow to invade into other tissue or organ areas. And I'll come to that further in a minute. But again, looking at the graphics on screen, you can see here what we call normal or healthy cells, where my pointer is. And then you can see where a cancerous tumor or a lump is being formed. These cells are growing uncontrollably. They often look a bit different as well. And when they start to grow even more, you can see that they're spreading through the tissue area here. So that's just a visual, simplistic representation of what might go on when cells become cancerous. And again, to speak to the fact that cancer is not just cancer everywhere, there are over 200 different types of cancers. And recent predictions or statistics from Cancer Research UK, one of the leading cancer charities around, says that 1 in 2 people in the UK will get cancer in their lifetime. The key here is early diagnosis, early detection. A lot of people can survive cancer, can beat cancer, and can go on to live really good lives even after a diagnosis. So when cells grow and they spread to other parts of the body, they can form secondary tumors. And this is what we mean by metastasis. So you can see here again in this graphics, the primary cancer, the primary site of that tumor is somewhere here in the bowels, and then it can spread through the blood vessels to distal parts of the body. In this case, we see it spread into the liver and also to the lung, where we get secondary metastasis taking place. So that's really the gist of what we mean by cancer. Now, scientists have an interesting way of actually talking about cancer to make it more less complicated, I should say, because it's quite a complex area to research. So scientists have a way of conceptualizing the complexities of cancer to actually describe it and define what areas need to be looked at in order to successfully this disease. And so what are the properties that cancer cell needs to make them successful? From a scientist perspective or a scientific perspective, they need to be able to do all these things here in this sort of circle that I've got here. And these are called the hallmarks of cancer. So the things that cancer needs to make sure that cancer is successful. And that might include things of like increasing proliferative signaling. You may say, what does that mean? I will break that down for you shortly. Being able to resist cell death, so cells won't die. Being able to induce angiogenesis, so that is creating or forming new blood vessels. And you will see how things like that become important in just a short while. So cancer, to be successful, need to be able to do a number or all of these things in order to be successful. And as I said, this is just a way that scientists use to conceptualize the complexities of this disease so that it can be researched appropriately. Each of these different areas individually or as a cluster in order to really unravel the complexities of cancer and to therefore be able to do something about it. So I want to explain it in a simplistic way. I did really think, how can I just make the point and make it clear? And I thought, let me just use a crazy road trip analogy. And bear with me, I hope this makes sense to you. And so really, let's go about starting the engine. Imagine two rebels, two friends, decided that they're going to do something, steal a car, hotwire the car, and that's how they're going to start the car. So that means they don't have the keys to the car, they have to break into the car and hotwire the car. And that's really what it is. In my workplace, when we begin to think about cancer, one of the questions we ask ourselves is, how can we tell that the horse is about to break out of the stables? And that means that in this case, the horse is cancer. That means that we need to be able to tell that a cell is going to become cancerous before it even becomes cancerous. And in this case, we're using a car and breaking into a car. How can we tell that something is about to break into the car being your cell? And if we can do that from the very outset, then that will enable us to prevent cancer. So prevention is the step before detection or diagnosis. And that's really where we're trying to get to. So two rebels break into a car, hotwired it, the engine has started, and in starting the engine, they promote what we call genome instability. So this makes your DNA unstable. And this is often where the mutations come from that really promotes the growth of your cells in an uncontrollable way. Of course, once that happens, they need the fuel to set things in motion. And with cancer, you can get what we call tumor-promoting inflammation, which means there's inflammation that is produced, which means that the healthy cells die out whilst the cancer cells tend to grow. Once things are up and running, I put here, everything will probably go wrong. And this means that they now have to sustain, the tumor has to sustain what we call continuous proliferative signaling. And that means it has to continue to grow. So imagine that as the two rebels who've hotwired the car, the driver putting their foot on the accelerator, and now things are very much in motion. To keep that motion going, they need to be able to evade growth suppressors. So there are signals in your body that can really trigger cells to stop them from growing, trigger what we call signaling cascades to stop cells from growing. And these processes are normally resisted. So checkpoints are resisted. Inhibitions for growth are normally resisted. And therefore, the cells won't stop growing. And if you think about this again in terms of the crazy road trip analogy, the brakes have failed. There is no brake here. There's no slowing down. It's onwards and forwards. And that's really one way to think about cancer cell growth. We get to another part of the journey, this crazy road trip. And it's this idea that we want to live forever or till death do us part. But that's a last resort. And I put that's a last resort because there's this conversation that's taking place that no cell really wants to die. No cancer cell really wants to die. In the same way, when you think about infectious diseases, virologists will tell you that no virus really wants to die. So even though that pathogen might be affecting the host, the death of the host is bad news for the pathogen because that means that it's likely going to die as well. But this is the idea of cancer cell. They want to be immortal, to live forever. And so they will resist cell death. And normally your body has programmed processes. So whereby if a cell becomes damaged, it would be programmed to die. It's a process we call autophagy. We've got apoptosis and a few others as well. You don't need to know all those words. But these cells resist death and therefore they do not die. Secondly, they need to enable recesses and the checkpoints that would normally enable cell growth, and therefore they won't die. So you can see already that a tumor is quite complex. It's quite complicated. And that's why sometimes cancers are really hard to treat, especially if we get them at the latter stage. Keep going. So keep going for as long as possible. There are no stops for comfort breaks. So imagine this as a trip on the motorway. There are no stops for comfort break. But eventually, at some point, you might think this car might run out of fuel. So cancer cells have a way of inducing what we call angiogenesis. And this is the formation of new blood vessels. And these blood vessels are able to get nutrients from other areas to feed the growing tumor. So they have a way of bringing the fuel to them. So imagine this crazy car on the road and something from an action film where some tanker filled with fuel is pulled up alongside, and somehow they're able to connect to that car in order to fill it with petrol. And this is another way to think about it. And finally, they must also deregulate cellular energetics. And that means that they will need to consume less than a normal cell will probably do. And so one of the things that we know about cancerous cells, especially solid tumors, is that they often tend to be hypoxic, which means that the oxygen level is lower. And so they have different ways of making their own fuel if they're not able to get enough fuel. So cancer cells basically are there just trying to survive, resisting cell death, and trying to spread and go as far as they possibly can. Finally, this leads to the idea of metastasis, which I've spoken to you about earlier in a previous slide, in that we have the formation of secondary tumors away from the primary site, where cancer cells break off into the blood vessel or into the blood system and then travels to distal areas where new tumors are formed. And of course, this is what we call here now activating resistance and metastasis. So cancer cells have a way sometimes of resisting anti-cancer therapy, can be resistant to chemotherapy, for example, and they spread into other tissues. And what it is here, you get the sense that we do not care what we damage or what damage we cause. On this journey, on this crazy road trip, our job is to go as far as possible. And as part of that as well, they tend to avoid immune destruction, able to find ways to evade detection by the immune system. So you can think of this in this crazy road trip as going undercover, whereby the traffic lights won't see them, the traffic cops won't catch them, because they're able to avoid that detection. And here on the screen are just various representations of organs in the body where cancer can spread to once they become metastatic, in that they can go to the liver, they can go to the lungs, they can go to the ovaries, they can go to prostate, they can go to the breast and other places as well. So this is just a sort of simplified way in my own creative imagination that I could explain to you cancer and to say to you, it's a bigger group of diseases. It's not just one answer fits all cancer. And we're going to become more specific now in terms of our conversation, because today's really about prostate cancer, which is one form of cancer. And I'm very, very pleased, having set that context, to introduce you to Dr. Amal Singh. Amal is a specialty registrar in oncology at the Royal Marsden Hospital, and he's also a clinical research fellow at St. George's University Hospital. Amal also, I know him all the way back from our days in Birmingham when he was at Birmingham Medical School, and it's just great to see how far he's come, and I'm pleased to introduce him to you, and he's going to explain prostate cancer. Over to you, Amal.
Thank you very much, Garrick. Thank you for inviting me to speak today. As we've already heard from Wayne and Garrick, this is a really important topic to talk about, in particular for Black men. As Garrick said, I'm currently working as an oncology registrar at the Royal Marsden, but also working at St. George's Hospital. So I'm a medical oncology doctor, meaning that I'm training how to use drugs and tablets and new experimental therapies to help treat patients with cancer and to try and improve their outcomes. I'm particularly interested in raising awareness in marginalized groups. So in particular for South Asian and Black men in particular, we know that they don't do as well as other ethnic groups when it comes to cancer treatments. And a lot of that is about improved awareness and education. And as we could see and hear from Wayne's experience, there's still a lot of way to go for not just healthcare, but also for the public and for families. So moving on. So it's a really brief outline of what I'm going to be talking about. I'm not going to be going into loads and loads of detail. I know we've got other speakers coming up that are going to be able to do that. And my main aim today is to just talk already and expand on what we've already talked about what is prostate cancer, a bit about the symptoms, a bit about the treatments, and what to look out for. So I think this is the most important slide in my presentation. This is from Prostate Cancer UK, and a really scary statistic is that 1 in 4 Black men will get prostate cancer. So looking at the total amount of people on this call, I've got 60 people. If we assume that's 50% of men, that's 30 men. Statistically, there may be 7 to 8 people on this call who either have got prostate cancer or developed prostate cancer. We've already heard Wayne's story. And I think this is a really important message to talk about with your friends, your family, and your circles. And you can see here, there's a QR code on this poster, which is a really quick thing you can do to talk about your risk and get an idea of what your risk of prostate cancer is. So I urge you, people that are listening, if you can, I'll put this up at the end of my presentation. You can just do this yourself, and it's really important. And I'll explain why it's important to get diagnosed early. So really briefly, what is the prostate? So the prostate is this walnut-shaped gland in between the penis and the bladder. It's a gland or an organ that we don't really ever think about until it causes problems. And if you can see there is a little tube going through that prostate, and that is the tube that drains a bladder of urine. So if you have problems with the prostate, such as cancer, that's why you get problems with urination or weeing, is because you can then get narrowing of this tube, which can then lead to reduction in the wee or the quality of how you wee. And so it's important for people to know where the prostate is and why it can cause problems. So when we talk about risk factors, these are things about what are the factors of a person which may increase their risk of getting prostate cancer. The most important risk, and this is in case of all cancers, is age. Unfortunately, as we get older, we are at higher risk of getting cancers, and that's related to the biology of what happens as we get older that Garrick also touched upon. In particular, prostate cancer, it is a disease that tends to affect older men, but as we've heard from Wayne, that actually what we classify as old is changing in today's society, but also it's not something, it affects people that are over 80 or 70, actually it's not. And in particular, when we say older people in this situation, as soon as you start getting over 45, over 50, that's when your risk really increases. So it's also important that we don't think of old as over 70 or 80 in this situation. I think we need to be aware that actually people in their 40s and 50s can be affected. As we've talked about already, ethnicity is important. Unfortunately, Black men are a much higher risk of getting prostate cancer. And we don't really know a lot of the reasons of why that is. There is likely to be related to the genes which we inherit, and different ethnicities have different patterns of genes and different mixtures of genes, which are likely to play a role in why they get cancer. And as I said before, sort of 1 in 4 risk of Black men. If you look at everyone in total, so that's including all ethnicities, the risk is 1 in 8. So family history, we've heard from Wayne about how his family had been directly related about prostate cancer, and actually age and your family history are the 2 real big players in what causes prostate cancer. So family history means people that in your family and direct family, so blood relatives that are affected by cancer. In particular, your people in your first degree, so that can be your brothers, on your fathers, and also your uncles. And it's really important that you have conversations with your families about it, as we've already discovered from Wayne. Alcohol can play a role, so increasing your alcohol consumption can increase risk of not just prostate cancer, but other cancers. And having a higher weight also can be a risk factor. So there's not a lot you can do about your age, your ethnicity, and your family history, but these are 2 things that people can do to try and help reduce their risk. Moving on to symptoms. The key thing to know, one of the key take-home messages, is that you do not need to have symptoms to have prostate cancer. And again, Wayne mentioned that he didn't have, well, he had some symptoms, but again, you know, it was very mild, and actually a lot of people don't have symptoms. So when you have prostate cancer that is small and localized to the prostate gland, that may not cause symptoms. And that's because that tube you saw that the prostate has within it, if the cancer does not affect the narrowing of that tube, you may not get any symptoms at all because your urine is not affected. However, as said, difficulty in weeing. So that can be starting to wee, the flow of the wee, and also stopping weeing. Other things are when you dribble after having a wee, that can also be a sign. And feeling that you need to wee very quickly after going to the toilet. That's another sign of there could be something wrong with your prostate. It's important to realize that this doesn't all mean, oh, I have prostate cancer. It can suggest that there's a problem with the prostate. Now, you can have things that aren't cancerous that affect the prostate, but these symptoms are common to prostate cancer and to non-cancerous issues of the prostate. So these are symptoms to be talking about and to be discussing with your families as well. So other things as well, including blood in the wee and also needing to wee more often, and severe back pain and weight loss. These are symptoms and signs of if the cancer is actually spread to other parts of the body. That's because prostate cancer very commonly can spread to the bones in the spine, and therefore that can cause back pain. So severe back pain and weight loss combined with these other symptoms are very worrying. And ideally, if those are signs, unfortunately, when the cancer is spread. And ideally, what we need to be doing is picking up patients that are actually have early prostate cancer. So it's only in the prostate, because that means that you are likely to be better and live longer and more likely to be cured. Wayne talked about the diagnostic process to some extent. So you can have a blood test, and that can be done by your GP, and that's looking at something called the PSA. And that's a prostate-specific antigen, which is just a very simple blood test that you can do at a GP. And that should be ideally what the GP should be doing if you say, I want to be looked at and checked over for prostate cancer. Next is the prostate examination. I think when men hear about this or hear about the idea of it, it can send shivers down your spine. I think it's really important to realize that this actually is a very, very simple and quick examination. The whole thing can be done in less than 10 seconds. This is where a doctor or another person may insert a finger into the back passage to feel the prostate. And that's really important to be able to assess whether this is something that could be cancerous, or is it something that may not be cancerous. And the whole process can be done very quickly. But understandably, men can be very, very reluctant and very shy about approaching this with the doctors. But it's something that once it's done, it's out of the way, and actually, it's often a lot less difficult than people imagine. You can have an MRI scan. So sometimes you don't even need to necessarily have a prostate examination. As Wayne mentioned, his cancer was actually picked up on the MRI scan, and actually wouldn't have been able to be picked up on an examination of the prostate. So MRI scan and blood tests are now increasingly being used to try and identify how you can be diagnosed with prostate cancer. And then once there are suspicions that there may be cancer, we take a sample of the prostate gland called a biopsy. So that's a procedure done in hospital, done in a day case, where you have a sample of the prostate taken. That gets then taken to a laboratory, and it gets looked at under the microscope to try and see what the prostate looks like. Now, this is going to be very, very brief about how it's treated. It depends on the size and the spread of the cancer. The earlier that you are diagnosed and the smaller the cancer, the higher the likelihood of being cured. And that's because if you have within the prostate and it's not spread to other parts of the body, you can have a surgery or radiotherapy to cure you. And the chance of you getting prostate cancer again is very, very low. You'll often be looked at by a cancer team, and that'll be a combination of different people. That's urologists, so that's surgeons, so like Professor Eden's going to talk later, but also oncologists like myself, who are doctors that deal more with medications and treatments to treat cancer. You will every patient should have a nurse specialist. So that's a nurse that can guide them throughout their whole cancer journey from the point of diagnosis all the way through their treatment. And it's a really, really, really helpful person to have along the way for your cancer journey. Someone that can answer questions and can also help with advice about how to speak to your families about other issues. They are also very good links about dealing with any psychological aspects of having cancer treatment, and they can make referrals and even talk through things with you. So, as I've said, the treatment of the cancer can be very variable. Often, we may not even need to do anything about the cancer and adopt things called watchful waiting or active surveillance. Now, these are methods of monitoring someone's cancer once we know it's there, but doing regular assessments, including blood tests and reviews, to see whether there needs to be a change, and we may need to think about doing things like surgery. So it's important to realize that if you are diagnosed with prostate cancer, that doesn't mean that you are suddenly going to have to go to hospital or have loads of treatment. That's not the case at all. Now, sometimes if you do need to have treatment, that can be lots of different things. So I was mentioned surgery, which Professor Eden will talk a bit more about, radiotherapy, which is where you have X-ray treatment targeting the prostate. You can have medications, and medications can be different types. And one main way we have of trying to treat prostate cancer is by giving you tablets or injections which can lower the level of testosterone in the body. And that's because prostate cancer is often driven by testosterone. So the cancer cells grow and divide because they are activated by testosterone. So by giving medications to try and bring those levels down of testosterone, we can then hopefully slow down the cancer. And chemotherapy, these are drugs given in hospital, often when the cancer is spread to other parts of the body, and we need to try and shrink the cancer down and stop it from growing if it gets to that point. So I've also briefly talked about this. What can you do to reduce my risk? These are things that you can, things that are in our control, which are not just important just for cancer, but also general health. So we know that regular exercise can be protective, eating healthily, and that's a balanced diet. So that's not necessarily avoiding eating certain things. So people say, I'm going to avoid eating sugars or avoid eating protein. That's not what we advise. We advise making sure that you eat lots of different things, but making sure it's healthy. And reducing alcohol, as I previously mentioned, alcohol is a risk factor for prostate cancer as well as other cancers. So just quickly going to try and address some myths which people may have heard about. It's an old man's disease, and as we've heard, that's not the case at all. It definitely is associated with getting older, but that doesn't mean that it's something that's an old man's disease. Prostate cancer is contagious. That's not true. As we've heard from Garrick about how cancer develops, it is not contagious, but it's often related to issues that happen at the cell level in your prostate. As I've talked about, the myth of I don't have any symptoms, therefore I can't have it. That's not true. As I've talked about, you can be completely asymptomatic and have prostate cancer. And it's really important that people take that message home. I can't pee properly, therefore it must be cancer. As I've said, actually, there are non-cancerous problems with the prostate. And therefore it's important to realize that just because you're having problems with weeing doesn't mean that it's automatically prostate cancer. And often that can mean that men say, oh God, it's going to be the worst case scenario. I'm not going to bother speaking to anyone about it because it's going to be cancer. Actually, that's really not the case. And it can sometimes be very reassuring to go to the doctors, have a test, and actually can be reassured that it's not cancer. So that's a really brief talk about prostate cancer. Thank you for listening, and I'll leave up this poster again. And again, I'd encourage you all to do the QR code or tell your friends and family about the QR code just to quickly check your prostate cancer risk. Thank you very much for listening.
Thank you very much, Dr. Amal. That was a fantastic update and insight into prostate cancer, and hopefully it's answered questions that people may have had. and maybe put some people's minds at rest, or actually may encourage someone to go and get tested immediately after this session. So thank you very much indeed for that. What I'm going to do, I've got a couple of questions. That we are going to put to Dr. Garrick and also to Dr. Amal before we move on to the next section. So one of the questions I have is, if you have been diagnosed with prostate cancer and have been put on active surveillance, what is the maximum time that should pass before you have the next hospital test? So, Dr. Amal.
Yeah, that's a good question. There are, as I mentioned, there are two monitoring methods. So there's watchful waiting and active surveillance. They're two slightly different strategies, but essentially they're both doing the same thing of monitoring things and seeing how things go. Now, in regards to what the maximum time should be, that depends a lot on the situation. So there's no set routine of you need to be checked every, say, 3 months or 4 months. That's really important to know. It's very dependent on your story and your cancer. So Wayne, you mentioned about your PSA went up a certain amount, and that's what triggered things. So it's all the PSA is a really important monitoring tool to see how often we should be frequently assessing someone. So it's important to realize that there's not often a set regimen. It depends on looking at each patient and seeing what their risks are. And I think if there's a question about, when's at maximum time, I think it's important, if you don't know when that's going to be, and that should be really specified in your consultation that you have, it's important to speak to your team and clarify when's my next appointment and why is that. So to answer your question very briefly, it's individual to that patient, and that depends on lots of factors, including the PSA and how quickly that's going up or down.
Excellent. Thank you very much indeed. Hopefully that answers that question. Second question I have is, what age do routine checks start in the UK? So routine checks with PSA, I think you addressed it somewhat during your presentation, but if you'd just like to sort of highlight that for us again.
Yeah, so we don't have a active screening policy on prostate cancer. So screening is where we are doing regular checks on asymptomatic people to find a cancer. So in, say, the example of breast cancer, women at a certain age get called to have mammograms. Now, we don't have that in prostate cancer, and that's because the PSA blood test isn't the most perfect measure of things. It can be raised in lots of situations, not just in prostate cancer. So what Prostate Cancer UK suggests, and I don't know whether, hopefully Professor Eden maybe later be able to explain, from my understanding and my ears, is if you've got family history, I think you should go anytime, essentially. If you've got like Wayne, your family, you discussed, you told your son to go get tested. It's really important to get checked out as early as possible. Now, from 45 onwards, I think is a really important age, especially for Black men, to get checked. And so, once you start getting to your late 30s, early 40s, especially if you have family history, you should be going forward to your GP and asking for a check.
Excellent. Thank you.
If I may add briefly to that, I think what Jana and Ava will share later on in terms of screening that they're trying to work on and develop, they might be able to advocate a bit further on that. I saw that Jana's just come onto camera, so I don't know if you want to chime in here.
Yeah, absolutely. Just to echo what Amal has said, that in the UK at the moment, we don't have a screening program for men for prostate the way we do for women for breast. And they would be about as common in the general population. So breast cancer in ladies is about as common as prostate cancer is in gentlemen. So part of the research that we're doing is trying to come up with a good screening program that will work well across the population. And one of the groups specifically that we're looking at are men of African and African Caribbean ancestry, so that we can try and come up with the best screening program that will hopefully work for everybody. But we're just not quite there yet. We're still in the researching stages at the moment.
Excellent. Thank you very much indeed for that. I noticed Dr. Eva has her hand up. Do you have something you want to contribute at this stage, Dr. Eva?
I was going to add on to Dr. Singh what he said. For those who didn't get to scan the QR code, you can just Google on your phone Prostate Cancer UK and risk checker, and then you can work your way through in terms of identifying your risk. And thank you, Garrick, for the analogy of the car. That was really good for cancer. Thank you.
Excellent. Thank you very much indeed for your input. There'll be more opportunities to ask questions, so please continue putting your questions in the chat on Zoom, and if you're on YouTube, then put it in the live chat as well, and we will take a note and answer them hopefully later on in the session. Over to you, Dr. Garrick.
Thank you very much, everyone, and thank you again for that, Amal. Okay, so what we're going to do now is we're going to have a panel conversation, and we have a number of individuals who have lived through prostate cancer or perhaps are currently living with prostate cancer, and we just want to talk to them, have a conversation with them, and just hear from them sort of lifestyle changes, the impact that prostate cancer has had on their lives, how it might have changed them, how it impacted their families, how it has touched on their mental health. And we are pleased to have, as part of this discussion, Orville Thomas, Paul Simpson, and I believe Andre Mars is here as well. And I feel like I don't belong in this conversation because I've not been affected by prostate cancer. So we're going to also invite Pastor Wayne back to this conversation, and I will chime in from time to time, but I think it'd be good for men, especially on the line, to hear from other men who've experienced this, what it meant for them, how it's affected them, and how you're doing right now. So let's kickstart it. And what I want this to be, I want it to be a very interactive conversation where we are talking to each other, and that might stir conversations from the audience members as well. And as I said, I'll chime in back and forth every now and again if I hear something interesting. So I'm going to start with you, Orville. Sorry, you drew the short straw. I'm going to start with you. Tell us about your experience, how it impacted your mental health. What support you've been able to receive, especially amongst other Black men, if there's such a thing. Let's hear from you.
First of all, thank you for inviting me to this forum. It has been very impactful and eye-opening at the same time. I've learned more now, I would say, than I have done in the year that I've been dealing with this. I was diagnosed back in November of last year, and to be honest, it's easier for me not to tell you what I've gone through to get to the point of knowing, because the way I've been handled wasn't great. The way I was informed that I had prostate cancer was by telephone, and it didn't come from a consultant. So that's where it all started for me, where it all went wrong. I got a phone call from an admin person who didn't know how to explain it to me, left me in limbo, and all I knew was I heard the word cancer and I had a meltdown, and I didn't even get to speak to a consultant for another 2.5 weeks. So it all started off really, really bad for me. Didn't understand numbers, no nothing. Eventually I did speak to consultants, got the understanding of what was going on and stuff, and then was offered what they call a brachytherapy. So I had 3 options, which was having the whole thing out, also brachytherapy, which I'm sure someone's going to explain, because medically I couldn't explain it, and also the radiotherapy. So, but I was fortunate enough to have brachytherapy, which I know is not offered to a lot of men with the diagnosis. So, and I think I was offered it because my urine flow was better than the norm. So that's why it was handed to me in that sense. I had to fight to actually have my procedure. It took me a further 4 or 5 months before I even had the procedure, which actually wasn't great. And it's only because there were certain things that were said to me by the consultant that in the end actually didn't transpire. And I had to use things that I knew because I worked for the NHS in order to get help. I had the brachytherapy on the 30th of March, which they told me went well. I'm on medication called tamsulosin. What I found with that, because beforehand I wasn't so bad with my urine flow, but what I found now, I have more of an urgency because of the procedure and the tablets in order to wanting to go. My mental health suffered greatly, I'm not going to lie, and that's because there was a lot of things that weren't not explained to me. I know Dr. Amal spoke about all the different procedures that they are leading up to, as you know, the PSA test, the rectal examination, the MRI, the biopsy, and I had every single one of those. But what wasn't explained to me, especially the biopsy, is what you will go through with the biopsy. And my experience left me very scarred. And I went home from that biopsy, having this thing they call a grabber. And they took 23 samples from me, left me bleeding for 5 days, and nobody explained to me that this was going to happen. And I had to find out for myself about things like men's sanitary pads and stuff like that in order to deal with this thing. And if it wasn't for my wife, be honest with you, I'm not even sure if I would have got through it, because I spent 3-4 days curled up like a small child in my living room on the sofa, just crying my eyes out because of what I experienced. So mentally, yes, it's taken its toll. I'm doing better now, but my whole experience has not been great.
Wow, thank you for sharing that, Orville. Pastor Wayne.
Yeah. Wow. You know, and there's two ends of the spectrum, because from the moment of my diagnosis, it seemed to be a whirlwind. I was operated on, I think within probably a week and a half 2 weeks after my biopsy, or it's a very, very short space of time. I was very well looked after. So I think we can see both ends of the spectrum here. Or I'm sorry what you've gone through. You had the brachytherapy, I had the prostatectomy, such was the severity of my prostate cancer. But thankfully, I'm out the other side. Great support from the doctors, consultants, the hospitals, and the follow-up as well. And just to add, you know, I literally this week Tuesday, I've completed 6 weeks of radiotherapy. At the time of my prostatectomy, I was advised that there may be a chance that I'll have to have radiotherapy further on down the line because of how close to the edge of the prostate my cancer was. Could be a chance that, you know, the prostate bed would need to be radiated, and I think it showed up on a PET scan earlier this year, and they said, yeah, we need to give you doses of radiation just to complete the treatment. So I've just finished that, thankfully, and again, and come out the other side. So yeah, it's both sides of the coin. Yeah, today.
Absolutely.
Sorry.
Go ahead.
Now, Andre, before I bring Paul in, we've got Andre Miles all the way from the US, and I've known Andre, I don't know, probably the best part of 25 years. And I remember when Andre was in hospital, and to be honest, I didn't realize the severity of what Andre was going through until I myself went through I had no clue that it was this severe what he had. But I know Andre has had a similar experience with prostate cancer. Andre, can you just share with us very briefly your experience of prostate cancer?
Well, yes, I'm kind of was in a unique position that you said, because I had been diagnosed on the UK side here, and I also had treatment after returning to the United States in 2008. So I must say, I was diagnosed on the 11th of May, actually. I remember the date, actually, the 11th of May of 2004. As for myself, I had background information because I had family history of prostate cancer, because my father had contracted the disease many years before. So I was pretty much educated on the actual prostate cancer as what it was and what it is, how it affected men, and then also the treatments that were available. Yes. So I was had my biopsy, and then I was referred to the surgeon, the consultant surgeon. And he expressed to me, because I was unique because I was 48 years of age when I was diagnosed, which was relatively unheard of at the time, because most men that were contracting the disease was in their middle 60s and further up in age. So I was presented with three options, and that was the watching and waiting, the observation. And what that entails is where the consultants and the providers, they would watch your PSA levels of the actual prostate and the PSA levels. And then in turn, they would present you with treatment if needed, because prostate cancer in itself, I learned that it's a very slow growing cancer, and it can be treated early. You can actually be cured of the disease. So the observation was one. Number two was the representation or the offer of brachytherapy. And my brother that spoke earlier, brachytherapy consists of implantation of radiation seeds into the prostate for periods of time to kill the prostate cancer. So in my particular situation, that was not advised because of the fact of my age, for one, and also the normal lifespan of males, that was not provided for me or suggested that I have that particular treatment. So also what was actually provided, and we were discussed, was the robotic radical prostatectomy. And that entailed going into the prostate area where you had 5 holes put into your stomach, and they use a robotic arm to snatch the actual prostate out of that area, put it in a bag so there isn't any leakage of those cells going into the body. So after meeting with the actual provider, my wife and I, we had great discussion. And again, I felt comfortable because it was a lot of shock concerning that diagnosis, but also I had great hope because I had someone to kind of mimic or kind of education from my father in his treatment period to know that it can be pretty much cured.
Andre, if I could just interrupt very quickly, what were the symptoms that you were experiencing?
The symptoms that I had was the urination that was not a normal flow. So I would sometimes urinate, and then I'd have to go back to the actual bathroom to complete the urination. Also, I had blood in the urine, and then I had pain upon ejaculation also. Yes.
Thank you. And thank you for that, Andre. And we will come back to you because we want to understand a bit more later on about the US versus UK and the treatment pathways. It was interesting hearing Orville's description earlier on, because there seems to be different levels of treatment, even London-based, perhaps based compared to, say, Hampshire, Surrey. So there's obviously discussions there. I want to bring in Paul. Paul, great to have you with us today as well. Just sort of share with us your symptoms. I mean, because I know you had your operation not long after myself as well. I think, and we were comparing notes and scars, and also how good was Professor Eden. I think we were all comparing notes on him as well. But no, it was what was it like for you? What was your symptoms and what happened?
If I go back to the beginning again, my father had it. A lot of you know him as Pastor Simpson. He had it I think about 10 years ago himself, and so I was actually, was tested like every year up from when I was about 40. Then I was they had the normal procedure of, testing and whatever. And then after that, my doctor just said, I think my PSA was raising just a little bit. But they said, let's just give you an MRI scan. So they gave me an MRI scan. That was fine. But then after that, they said, let's just give you a biopsy as well. I think that's strange, not seeing anything. But it was there at the biopsy they found the cancer itself. It was quite a shock. It was a weird situation because before that, I got a letter from the doctors to say, like, can you come in and see us at there's a Fleet hospital. I didn't even know there was a Fleet hospital there. So when I went in, I just thought, they're just gonna give me the all clear. And basically she gave me the news, and it was a weird experience. If anyone's not gone through it, it's a weird experience. It's like you're not there, you're out. It's an out of body experience in the way of saying, is she actually talking to me about this? That was a weird time. And even around that sort of time, it was a case that she gave me options of whether to have medication or radiotherapy or have the operation itself. She said, look, go away, think about it, talk it through with your family. And I think I came around your house, Wayne, didn't I?
Yeah.
We had a chat and just said, look, I think I've made up my mind what it is going to be, but how did you go through it? And I think people need to do that. They need to share and talk to whoever's got it, whoever has had it, talk to that person. And because it's a great help.
Yeah.
I went away from there and speaking to yourself, not just you and Bev, it was the whole family, because it is a family thing. They're going through it with you as well on that.
Thank you. Thank you so much. Sorry, Gary.
No, if I may pick up on that, because I think that's an incredibly important point. He came round and had a chat with you. And one of the problems in our community is that we don't talk about these things.
Especially
I was talking to someone who was 23 years old 2 days ago, and his dad passed away earlier this year. And he found out that his dad died from prostate cancer, and that he was being treated for prostate cancer. And he only found out after his dad passed away. And that messed him up. He couldn't come to terms with that because it's just not a conversation. What is it, do you think? It is this idea among Black men that we must remain strong, that there are certain things that even our younger children should know as it relates to our health. What's that bravado? What's that all about?
I definitely will interject on this one. First and foremost, it starts with our upbringing. We've all been brought up with this thing where, especially us who have come from the West Indian background, our parents didn't tell us a lot about their background, stuff that happened to them. It was always a taboo thing to talk about their past. And because they didn't do that, we have grown up with that thing of not sharing. Because even if we do something wrong, we don't share it. When you're brought up in the church community, then the other side of it is bringing shame to the family. Because if there's something that you do, then that becomes problematic again, because it's not just you it affects the family. I will also say on the flip side of what Paul was saying in terms of talking, I spoke to a couple of people who I knew had been through it. And I also joined a prostate cancer group on social media. Herein lies another issue, because you can then get bombarded with a lot of information that actually doesn't even belong to you. So what happens is that, for instance, on social media, I joined the group and it was great, but then it was information overload. I spoke to 2 people who'd been through it, and that was great. But what I then had to take from that, and it took me a while to adjust, was because what happened to them doesn't mean it's going to happen to me. So again, I was being filled with a lot of information that I still didn't have a clue, because my thing is, oh my God, is that what I'm going to have to go through? So therein is a few sides of the coin.
Mm-hmm. I wonder if Paul or Andre's got any perspective on that as well. That's great insights, Orville.
Yeah, I can relate to that. I can relate to that. It's a case of, you know, like I said, I only have a certain amount of people I can say go to, and I thought with Wayne, I mean, we're really good friends for how many years now, and I sort of trust that sort of person, and it's a case of like, it's sometimes also going back to, you know, the issues of like your mental health as well. I think even with that, I think you need, you know, the stigma with, you know, sort of going to, you know, other people getting counselling and things like that. I'm my hands up. I was the same. I was thinking I don't need counselling, but in the end, people were actually saying to me, "Look, you've been through so much. You need to have that counselling," you know. And that's, you know, as men as well, not just being black, just being as men. You know, we need to get that information. We need to get that sort of to go to people and just to get your soul out there to say, look, this is what I've gone through, you know, and that takes you through the other end. It's not like, yeah, sometimes we say, yeah, God will take me through, but you need more than, you need actions with that as well. Really.
Yeah. Thank you. Thank you so much for that. I'm conscious of the time, and we've got Professor Eden, who's going to be coming on next. But just to say thank you to Andre and to Paul for sharing. And just to say, we're going to be doing more of this because we need to talk. It's plain and simple. We need to talk. You know, when I received my diagnosis and went through what I went through, I do talk about it. I'm absolutely quite open about it. And it does encourage other people to say, actually, you know, come and have a conversation. And they themselves go off and get checked. Very often, you know, there's nothing wrong, but it actually puts their mind at rest. So, guys, thank you so much indeed for sharing and being so open with us. And we'll probably come back to you hopefully before the end of the segment, at the end of the session today. But I'm really pleased to welcome our next guest, who's Professor Christopher Eden. And I would say he knows, I see Paul clapping his hands, he knows Paul intimately, he knows Andre intimately, and he knows me intimately. And, you know, we owe him a debt of gratitude, certainly in the work that he does and continues to do. He's world renowned and he's a world leader in terms of surgery for prostate cancer. So please welcome Professor Christopher Eden as he comes and shares with us the treatments that's available for prostate cancer.
Well, thanks very much. And hello, especially to Andre, Wayne and Paul.
Hi.
Yeah, I know you well. So it's a bit of a tough ask, being asked to talk on something for 15 minutes that people spend a week at a conference discussing. So what I'm going to do is to keep it fairly brief. Now, the rider on my talk is that I'm a surgeon, so I don't just see things through a surgical prism, but I do have a bias. I'd like to think that the bias is justified through what I've seen and the evidence that I've read in the literature. So what I will do now is to share my screen and get this talk up and running.
We seem to have lost Professor Eden. He'll rejoin. We'll see if we can rejoin. Bear with us a second. There we go. You're back, Professor, and we can see your screen as well. You're sharing your screen.
Perfect. Okay. Okay, so you can see that, Wayne, can you?
What we can see is you're clicking to open Zoom. We can see your web screen. We can't see your presentation yet, though.
Okay. It says you are screen sharing.
Oh yeah, you're sharing your web page, not your presentation at the moment. Have you got a PowerPoint you want to share?
Yeah.
Yeah, if you click on the share screen button again at the bottom.
Yeah.
And if you highlight your PowerPoint screen and click share on that one, that should then show us your PowerPoint screen. Yeah, that's it. Great.
Is that okay?
Yeah, that's great. Thank you.
So this is me. I no longer work in Guildford. I work just at London Bridge Hospital in London. In terms of treatment options, it is a difficult one talking about treatment options, because the treatment options will depend very much on the patient, but also to a large extent on the doctor who's talking to the patient. What I would say about active surveillance, though, is that really is something which is the default option for low-risk prostate cancer. In other words, Gleason 6 and low-volume Gleason 7 prostate cancers. And active surveillance really takes the form of monitoring with PSA, MRI scans, and prostate re-biopsy at certain intervals, and looking for evidence of disease progression. And if there is disease progression, then changing the active surveillance to active treatment. Focal treatment is also worth discussing at this point, before I then talk mainly about surgery, radiotherapy, and the differences between those two main treatment modalities. So really the whole purpose of focal therapy is to treat either with heat, that's high intensity focused ultrasound, which heats the prostate, or by freezing, which is cryotherapy, half the prostate. Whole gland HIFU and whole gland cryotherapy really is pretty much stopped now. These two modalities are used to treat half the prostate on the basis that many patients will either have disease in one half the prostate, or there'll be a dominant cancer in half the prostate. And by treating only half the prostate, you also significantly decrease side effects, notably incontinence and impotence. There is a rider, though, and the principal rider and the principal concern that we have regarding focal therapy is that if you biopsy the prostate a year after focal therapy, you will find residual or recurrent prostate cancer at about 30%. Now, the advocates of focal therapy would say, well, that's not a problem because it's repeatable. But there's very good evidence to show that if you operate on these guys who have had HIFU or cryotherapy, the surgery is more difficult. And that increased degree of difficulty translates into poorer continence, poorer potency, and poorer cancer control compared to if you'd operated on those patients de novo. In other words, at the beginning of their cancer pathway. So surgery and radiotherapy are still very much the mainstays of treatment. Surgery, obviously, removing the prostate. If the cancer is definitely confined to the prostate, the patient will definitely be cured. There's no doubt about that. The problem is that higher grades of cancer, in other words, more aggressive cancers and higher grades, in other words, more extensive cancers, will often have cancer cells outside the prostate at the time of diagnosis, which simply don't show on the scan. So some patients who have surgery will need to have radiotherapy if there has already been some spread to mop up residual cells. Radiotherapy approaches the problem from a different standpoint, and the aim of radiotherapy is to cause damage. The idea is that healthy cells recover, cancerous cells don't. Unfortunately, there is some overlap. So you will find that some cancer cells are not sterilized by radiotherapy, and some healthy cells will be adversely affected by the effects of radiotherapy. And radiotherapy, as we've heard already from Orville, can be delivered from the inside, what we call brachytherapy, by implanting radioactive seeds, or from the outside by external beam radiotherapy, or indeed a combination of the two, what's often called a brachytherapy boost. In other words, you give the brachytherapy plus external beam radiotherapy. And the rationale for that is that the more radiotherapy dose you give to a cancer, the more likely it is that you'll get rid of it. There is, however, a downside, and the downside is that if you look at the literature, you will find that combination therapy generally quadruples the rate of grade 3 or serious genitourinary toxicity, in other words, bladder symptoms. So as far as surgery is concerned, there are certainly significant advantages. There is the certainty of a final grade and a final stage. In other words, you know definitively exactly what the aggressiveness and the extent is. But crucially, you also have a target PSA of 0. And that makes it very easy through a simple blood test to interpret how you are in terms of cure. Importantly, if you have surgery, then radiotherapy afterwards is very well tolerated, but it doesn't work the same the other way around. In other words, if you've had radiotherapy, the surgery is difficult, and impotence rates 100%, or approaching that, and incontinence rates are certainly extremely high, in excess of 50%. The other big advantage of surgery is that if you do have an aggressive tumor, it's easy to use as part of multimodal therapy. A lot of the patients won't need to have the other modalities if PSA remains 0. But if the PSA does rise, then you can combine hormonal therapy and radiotherapy, and you have much better local control of the disease, in other words, urinary symptoms, and not worrying about the main bulk of the cancer invading the pelvic nerves and causing pain and bleeding. The other big plus about surgery is for younger guys, and this relates to the radiation risk of bladder and rectal cancer, which is approximately 3-fold. And this tends to occur 15 to 20 years after radiotherapy, so is a bigger concern for younger patients. There is a big problem, though, with surgery, and the biggest problem with surgery, I would say, is that there is a huge range of results. In other words, going all the way from really good results, really bad results, and most surgeons, of course, will get somewhere in between, because that's what average means. And there are a number of factors that will affect patient outcomes from the point of view of functional results after prostate cancer surgery. So younger men have more reserve physiologically. They'll tend to have more reserve for potency and for continence. If you're slimmer, it's easier to do the operation. technically. If you're starting off already with erectile dysfunction, you're certainly not going to have better erections after the operation than before. So diabetes and hypertension, two things which are known to decrease erectile function as a matter of course, quite independent of prostate cancer surgery. And to some extent, having a larger prostate as well may make the operation technically more difficult. But the really big elephant in the room, which no one wants to talk about, is the surgical factor. In other words, who is doing your operation? And this is a graph which used to be produced once a year by the British Association of Urological Surgeons. And what it does along the x-axis is to identify individual surgeons, and on the y-axis, the number of operations that that surgeon does per year. And they've actually stopped doing this. They stopped 6 years ago, I think largely out of embarrassment. And when I had this published in a newspaper article, they tried to get me to get the article withdrawn because it is embarrassing. You can see that the average number of cases done per surgeon is 39, so that's less than one operation a week. But if you have a look at the tail, in other words, the bit underneath the average, going off to the left of the midline of the graph, you'll find that there are surgeons out there doing really, really small numbers of operations per year. And if you look at the number of surgeons who do over 100 a year in the UK, it's only just over single figures. And this really hasn't changed very much over a period of time. And if you use a figure of 250 cases per surgeon for the steepest part of the learning curve, you'll find that most surgeons will take 7 years just to overcome the steepest part. There are a number of technical factors in surgery that have significantly improved the functional outcomes. One of the things that I'm particularly interested in is a different surgical approach to prostatectomy. So instead of going over the top of the bladder, which is the usual approach, which disconnects a lot of the anchor points of the continence mechanism, the so-called retsis-sparing approach seeks to do the prostatectomy from underneath the prostate. It roughly improves early continence threefold. I'm going to share some of these slides with you, but not all of them because they're a bit technical. It also cuts down on the operating time. It looks as though there's less penile shortening, Peyronie's disease, better nocturnal continence, and so on. And there have been 5 randomized controlled trials, in other words, the highest level of evidence that there is, which have shown this. It also applies to patients having their prostates removed who previously had radiotherapy. There's a significant advantage for those patients. And it looks as though also that patients having this approach will have better erectile function. Now, part of this, I think, is because of the way that you're forced to do the nerve preservation. So this is nerve preservation on the right side of the prostate. The prostate's being lifted up by the instrument on the left. And the instrument on the right, which is scissors, is gently teasing the right nerve bundle off the back of the prostate. The prostate is a bit bruised because this is 2 weeks after this man has had his prostate biopsy. So that bruising is blood within the prostate itself. And this is another patient who is immediately continent and immediately potent. It isn't suitable for everyone. There are some patients, in other words, ones who have cancer in the front of the prostate who are not suited to it. I'm going to fast forward because you don't need to know all of this stuff. One of the other significant advances in the nerve preservation side of things is avoiding using cautery clips and sutures once you've done the nerve preservation. You can see the nerve bundles coming up as a triangle on either side to meet in the midline at the top of the screen where the urethra is being cut. You can see there's a silver piece of metal poking out of the urethra, what we call a sound. And the advances in using this powder, which is called Arista, and it looks as though this powder allows you to decrease the amount of maneuvers that you make on the neurovascular bundle, better preserve its integrity, and maybe also create a gel matrix which prevents the mediators of inflammation which are harmful. They cause vessel thrombosis, they interfere with nerve recovery and so on from getting at the prostate. So this is being published and presented, and typically, and I know, Wayne, one of the things that you wanted to know is what could patients expect in terms of results from surgery. Well, with a rectus sparing approach, there's a 90% probability of continence at 4 weeks and 99% at 12 weeks. For continence, for potency, those figures I thought I had on this presentation, but they're approximately, here we go, so approximately 80% in previously potent patients who are not diabetic, who have full nerve preservation, and who are under the age of 70. So that gives you a very rapid overview on treatment options with a definite surgical bias.
Thank you so much, Professor Eden. A really useful discussion there. And what I would encourage people, if you have any questions, then please put them in the chat for us, and we can put some questions to Professor Eden, Dr. Amal, and the other doctors on the line as well. So please feel free to put your questions in the chat, and we'll go back over them in a few minutes. Now, we've got a couple of questions on YouTube. We'll come to those in just a couple of moments. I want to again thank you, Professor Eden. That was really really in depth, really detailed, and really interesting, and also interesting to see some of the work that you've been doing there. Please stay on the line. We will come back to you in just a few more moments. Wait for a few more questions, and then we'll put some questions to yourself in just a moment or two. But let me just quickly invite Andre back into the discussions for just for a quick moment. We heard earlier on Orville talking about his treatment here in the UK, and I shared my treatment in the UK. There seems to be disparities, certainly from London out to the suburbs. Andre, just sort of talk to us. You've had treatment in the UK back in 2008-9, I think you said, when you were initially diagnosed. So you had your treatment there. You then you moved to the US, and you had subsequent treatment in the US. I'm interested just to understand, because correct me if I'm wrong, I know, and possibly the doctors on the line could correct me, but I think the results and certainly the take-up of men being examined for prostate cancer, etc., in the US is probably better than the UK. Just trying to sort of get an understanding as to maybe the difference in terms of treatment pathways, UK versus US. If you could share your experience, UK, just very briefly in about a minute or so, UK versus US, how you think the treatments went in each case.
Yes. Well, really, returning after receiving treatment here in the UK and returning back to the United States, the only treatment that I had was actually because the actual prostate cancer had returned once getting back to the United States in 2008. So I believe, just as yourself, I experienced spiking in my PSA numbers. So then in turn, I was recommended by the urologist there to undergo 45 sessions of radiation treatment and so forth. So the bulk of my treatment actually was done in the UK. And then, of course, there was a minimal work done thereafter because of reoccurrence when I got back to the States. Yes.
Okay. So how did you find access to information and access to help, again, UK versus US?
Yes, I would actually call it even Stevens. Okay. To tell you the truth, Wayne, Because as I believe it was Orwell, he said that you come to a point where there's so much information thrown at you as a patient. You throw your hands up in the air because first I'm confused anyway. How did I get this disease from initial, and then in turn, what am I supposed to do about it? So yes, I would say it's about even Stevens. There are lots more funding, I would believe, in the United States, because it all boils down to money, the dollar, the pound, in order to enhance the treatment for patients, whether it be here in the UK and also in the United States. But now here, when I was diagnosed, in England, when I was initially diagnosed, it depends on NHS versus private coverage, which I had. I found that out also. That was an interesting piece there, where I had Bupa coverage. So I know in the NHS, you can wait much longer for treatment under the NHS system. But if you have private coverage, then things tend to move along quite quickly or more quickly, which is vital when dealing with cancer, whether it be minimal or whether it be life-threatening at the end of the day. Yes.
Brilliant. And just one final point. What about awareness? Do you think there's a greater awareness in the US about prostate cancer, especially amongst Black men versus the UK? What are you seeing?
In the US, I believe because of the numbers of people here in the United States, of course, the awareness is going to be larger. And then also because of prominent individuals. We have television personalities here in the United States that have, and then with the increase of technology that we have today, you can click on your computer and instantly you have information. So that helps quite a bit also. So I believe that with the influx of personalities sporting, one gentleman that comes to mind, and I watch this, I used to watch him every morning to get the weather, is Al Roker here in the United States, who was a weatherman. And he was very forthcoming with his prostate cancer diagnosis.
Cool.
So people are gravitate normally to success.
Okay.
So when they open their mouths, we listen.
Sure.
So, and then, yes. So I would say there was more awareness here in the United States and the Black community also versus the UK. Yeah.
Great. Andre, thank you so much for that. And thank you for your insight. And we'll speak again later, but thank you so much for that.
Yes.
So I've just got a couple of questions in the YouTube chat, and I'll put them to Professor Reed and whether Dr. McHugh, Dr. McGrath, or Dr. Mal want to respond. So one of them, first question, and we've touched on this, but at what age do they start testing in the UK? Now, I know we mentioned that there isn't an active screening program, but at what age do they actually start testing in the UK? Is there a minimum age? Is there a recommended age?
Well, you're allowed to ask your GP as part of the NHS prostate cancer risk management strategy from the age of 50 on. But I would argue that if you've got risk factors, particularly if you have a positive family history, if you're Black, or indeed a combination of the two, that's probably a decade too late. So I would advocate starting to test PSA, if only to establish a PSA baseline from the age of 40. And there's certainly very good evidence to show from both sides of the Atlantic that knowing your PSA in your early 50s allows you to be stratified into risk categories, which in turn then will dictate the intervals between PSA screening. So in other words, if your PSA is less than 0.5, it's perfectly safe to wait for another 4 years. If on the other hand, you're 50 years old and your PSA is 2, statistically, you have a high probability of developing prostate cancer, and that interval probably ought to be as short as 6 months.
Wow, it's interesting. Thank you. Thank you very much. More on that, but for the time, I'll quickly move on. There's a question that says, I have an adult son in his 30s. We speak at times about prostate cancer health. However, how frequently can he request that he is tested, as he doesn't know of his family history. So he's in his 30s, adult child, speak at times about it. I suppose it speaks to the previous question, just answered that they can request a test at any time.
Yeah, I mean, if he's black, I'd advocate having it done at the age of 40. And then subsequent PSAs, I think, are very much going to be determined by what the baseline PSA is. If it's really, really low, then I think it's reasonable to wait for up to 4 years. On the other hand, if it's above 1, it ought to be done in a year. If it's above 1, it ought to be done in 6 months.
That is really interesting.
And this is almost identical evidence from Europe and from the US, showing that the long-term fate of men with elevated PSAs in their early 50s. So you can identify the people who are going to go on to get prostate cancer. And the screening program doesn't have to be every man having a test every year or every 2 years. Some men will need closer scrutiny than others. And that obviously has big implications for resources.
Absolutely.
If you combine then what a lot of departments are doing in Europe and also in the US with adding on to that MRI scanning, genomic classifiers, you can then further hone down the ideal screening interval for patients and not have people over scrutinized and therefore resources not being wasted.
Personally, that's really interesting because I'm just thinking of my own experience and where my PSA was in my sort of late 40s, early 50s, and it was above 1. And for me, there was this magic figure of 3. And as long as you don't hit 3, you're fine. So in my head, I think, great, it's not 3. Actually, not knowing that I should have probably been insisting much, much earlier. I'm talking years earlier. Because there was slow increases in my PSA, given my family history, et cetera, et cetera. So that's really, really interesting. Thank you for that. Just a quick couple more and then we'll move on. Someone says, does any other thing or disease cause erectile dysfunction apart from diabetes and hypertension?
Yeah, lots of things. The commonest being age. It's physiological to have erectile dysfunction. You'll find that patients, well, not patients, individuals have furring up of arteries. If it's the heart, you get a heart attack. If it's the brain, you get a stroke. But erectile dysfunction is a normal part of the aging process. So coronary artery disease, which tends to be exacerbated by diabetes or accelerated by diabetes, hypertension, the treatment of hypertension, peripheral neuropathy, spinal injury, the list goes on, neurogenic. So those are the commonest categories, but it is a normal part of the aging process. So your expectations from treatment should also very much be determined by who it is you're treating. If you're treating a man in his early 70s with a bulky and aggressive prostate cancer, you want to aim to get that man's cancer out and have him continent. For high grade and high risk prostate cancer, erectile function preservation really isn't a realistic goal. On the other hand, you have someone who's young, who's potent, low volume disease. Very much so, you want to have a trifecta. You want to have potency and continence and cancer control, and all 3 are eminently feasible in most of the men in that category.
Thank you. One final question before I hand over to Dr. Garrick. What if you are in your 40s and your GP says you are too young? What can we do to get tested?
Well, I think be insistent. If you've got a positive family history, if you're black, then you ought to be tested in your 40s. The difficulty is that the NHS prostate cancer risk management strategy specifies 50. But I think most GPs actually, if you can make a reasonable case for being at higher risk, in other words, positive family history, and black or a combination of the two, then they will relent. It's much easier as a GP to say yes than no. It's a pretty cheap test. We know that it's not completely specific for prostate cancer, but it's a really useful way of identifying patients in whom we ought to take a closer interest in the future.
Fantastic. Again, thank you so much, Professor Eden. Sorry, Dr. Eva, you have your hand raised.
Just to add on to that, for what Professor Eden has said, for those who are struggling with their GPs in terms of getting the PSA test, recent discussions with Prostate Cancer UK, they say that if you're experiencing that difficulty, contact PC UK. They have specialist nurses, and there are some additional information they can give you that you can then take back to your GP to make sure that you have that PSA test, especially if you're Black.
Excellent. Thank you so much. And I just want to, again, say a huge thank you to Professor Eden. Thank you for giving up your time today. I know you're actually doing a clinic, so this is in between sessions. So we just want to express our sincere appreciation to you and look forward to speaking with you again in another session in the not too distant future. Thank you so much.
Okay. Well, I'm going to leave now and get on with the rest of my
Thank you again. Thank you.
Okay. Nice to see you all.
Thank you. Bye-bye.
Bye.
Over to you, Dr. Garrick.
Thank you very much. Really important discussion there. Gentlemen, we have made you aware. We've had conversations in giving you knowledge and all the information that you require. However, we don't just want to talk about these things. We want to do something about them. So we want to go into a session now we call advocacy, where we'll advocate for some of the things that we can do, actively engaging going forward to help to reduce the impact of prostate cancer, especially on Black men. So I am very, very pleased to introduce to you Dr. Jana McHugh and Dr. Ava McCrowder. Dr. Jana is from the Institute of Cancer Research. She's a clinical research fellow there in oncogenetics, and that's just the genetics associated with cancer, in case you're wondering what that word means. And of course, she's a senior registrar in oncology at the Royal Marsden Hospital, which you may know is a comprehensive cancer hospital. And Dr. Ava is also from the Institute of Cancer Research. She is a research projects coordinator, oversees clinical trials for prostate cancer. And of course, she is a scientist by training with a research background in breast cancer. So very, very important people that we have here. And they're here to tell you all about the profile study. And I'm not going to say any more on that. I just want them to tell you about it. Please do pay attention and do engage, and we'll follow up after their presentation. Great to have you both here. Over to you.
Perfect. Thanks a million, Garrick. I hope everybody can hear me and see the slides.
We can. Great.
Magic. And just thanks again for organising such a great session and inviting myself and Eva along. So I'm going to talk about the profile study, which is a research study that's ongoing at the moment at the Institute of Cancer Research and the Royal Marsden Hospital. It's going to be looking at prostate cancer screening in different groups of men, but one of the groups of men we're looking specifically at is men of African and African Caribbean ancestry. And we're hoping that we'll be able to improve our understanding of prostate cancer in these men. So prostate cancer is the second most common solid tumour worldwide in gentlemen. It's the most common cancer affecting men of African and African Caribbean ancestry. And currently, like we've already said, like Dr. Amal, Prof. Eden have already touched on, and Garrick and Wayne, there isn't a population screening programme in the UK at the moment for prostate cancer for men the way we have for breast cancer for women. We did talk about some risk factors earlier. I know Dr. Amal went through this in a lot of detail. So as men get older, the risk of prostate cancer does increase. But again, it doesn't mean this can't affect younger men. Your genetic origin does affect your risk of prostate cancer. So again, like Amal mentioned, 1 in 4 is the risk for men of African and African Caribbean ancestry in the UK, whereas for the general population, we'd say the risk would be closer to 1 in 8. Again, men with a family history of prostate cancer are at much higher risk of developing prostate cancer in their lifetime than a man who doesn't have family history of prostate cancer. And then there are some rare genetic changes that some men may carry that put them at higher risk of prostate cancer. An example of this would be the BRCA genes. So you may have heard of these, that they tend to be more associated with breast cancer risk in women, but they do put men at higher risk of prostate cancer. So if they run in somebody's family, the gentleman in the family should be getting checked for prostate cancer the way the ladies are getting checked for breast and ovarian. There's another set of genes associated with Lynch syndrome, which is more commonly known as being associated with colon cancer. But again, if this runs in somebody's family, they should be getting checked for prostate cancer as well. So the profile study is a big research study. We're aiming to recruit 1,050 men. We want to involve 350 men of African and African Caribbean ancestry, 350 men with the family history of prostate cancer of European ancestry, and then 350 men of any ancestry who carry some of those higher risk genes, like the BRCA and Lynch ones I talked about. So those are the three groups that we're looking at in the study. So like we had said, we don't have a screening program at the moment in the UK for prostate cancer. So the profile study is going to look at how can we come up with the best type of screening study for everyone in the population and what's going to work the best. So like Prof. Eden and Dr. Amal mentioned earlier, using an MRI scan can be very helpful. Really, the only way to know exactly what's going on down at a cell level in the prostate is really to do the biopsy. But we're also going to look at some of the genetics, so some little markers along people's genetic codes to see if that can help identify people at higher risk of developing prostate cancer in their lifetime. And we use these along with the PSA blood test. So we're hoping that using a combination of these tests will help us to find the men who have the higher risk prostate cancers. And specifically, we want to know if the genetics can help us predict men who will have a higher risk type of prostate cancer on their biopsy. And that's essentially what we're looking at. So we want to include, like I said, men of African and African Caribbean ancestry aged 40 to 69. And then the second and third groups are men with a family history or men with those high risk genes where they carry them along with their family members. So like Prof. Eden had mentioned, you know, we want to try and develop the best screening program we can. So some of the data that we'll hopefully be able to get out of the profile study is whether only higher risk men need screening very, very frequently. So should some men be screened more frequently than others based on maybe their genetic risk, their family history, their genetic ancestry. It might turn out that some men are suitable for low intensity screening, you know, like Prof. Eden mentioned, maybe once every 4 years, whereas some men may need to be screened a lot more frequently than that. And then we're going to look at what have been the best tests for screening gentlemen, whether genetic screening can be used as part of the mainstream, how good the MRIs are performing, and whether there are other biomarkers like things like urine can be used as well. So we want to ask men aged 40 to 69 to get involved in the study. We also need to make sure these men have not had prostate cancer themselves in the past, and they must either have Black African or Black Caribbean ancestry. And we're defining that in the study as both parents and all 4 grandparents of that origin. We want to let men know about the study. We ask gentlemen to fill out just a one-page expression of interest, and then our research team will get in contact with them, and then we need the GP to make a referral to get up and started into the study. This is what the study overall looks like. So men aged 40 to 69 with African and African Caribbean ancestry can get involved. They send in the expression of interest form, and then we get in touch via telephone just to see if they're suitable to be involved. There are some things that may mean that gentlemen aren't ideal for the study, but we would discuss that over the phone. And then if gentlemen are happy to come to us, we arrange for an appointment with us at the Marsden, and we discuss what the study is going to involve. Of course, men can decline at any point. This is only research. But if they're happy to be involved, we go on and do a consent. I'm going to talk a little bit now about the two arms of the studies. So gentlemen can decide what one they want to be involved with. So for a lot of men, they decide to be involved in the first arm of the study, which is where we do a PSA blood test once a year, every year for 5 years. If their PSA reaches a certain number, which is based on their age, so men aged 40 to 50, if their PSA is over 1, we go on and organise an MRI scan and a prostate biopsy for them. Some men, their PSA may already be at that, in which case we then offer them to go straight for their MRI and then arrange a biopsy. For some men, it's possible they never actually end up reaching the threshold on PSA for the MRI or biopsy, and they just continue with the yearly PSA test. Other men decide, actually, I want the full MOT, I want my PSA checked, and I'd like the MRI scan and the biopsy as well, so I know exactly what's going on and where I'm at. So if that's the case, then we go ahead and we arrange for the MRI scan to happen and the biopsy then after the MRI has been done. If we found anything like cancerous cells, we discuss all of the treatment options that are available. So like Professor Eden has mentioned, surgery, radiotherapy, and the point of that is that we can offer the most amount of treatments once we catch something early. At the moment, we've done pretty well with recruiting men in the family history group. So we're nearly at the 350, but it's taken us a little bit longer recruiting our gentlemen of African and African Caribbean ancestry. For a number of reasons, and we're very grateful to Garrick and Wayne for inviting us along today so that we can promote and reach out and ask gentlemen to become involved in the study, because it is such important work, and that it can be of benefit to both a gentleman himself and then for the future as well. So just to emphasize that men can choose which arm of the biopsy or of the study rather they'd like to be involved with. So they can just have their PSA checked, and we'll explain all of that at their initial meeting anyway. We are trying our best to raise awareness, so we've created some posters. PC UK have been helping us to raise awareness of the study as well. We're trying to, link in and reach out to people. So if anybody wants us to come and speak at any other events, we're very happy to do that. And please, get in touch with us, and we'd be more than happy to do that. And we also have a promotional video for the study, which I'm going to play just in a moment. It's available on YouTube, and some of the men involved in the study and some gentlemen who've been working closely with us helped us to come up with the ideas for the promotional video and are involved in it. So I'm hoping this is going to play for me now. Oh, sorry, it didn't. Apologies.
Jana, I think it's because you have a timer on your slides. If you remove the timing of the
Timing.
slide, then the video will play, I think.
Perfect. Sorry,
So if you untick use timings.
apologies. Sorry about that. My technical skills. Luckily, Eva's here to save the day as usual. Sorry.
There's no sound for some reason.
Most people talk about things about life. You're more likely to speak about topics that are difficult.
Is that working?
It was working. If you could start it again.
Perfect. Sorry about that.
You know, barbershop is where most people talk about things about life. You're more likely to speak about topics that are difficult a lot more freely. Besides making friends, you start talking and then you just find out that, oh, what? I'm not alone.
The way I see it is our barber is like our therapy session where we talk about our problem and he helps us and we feel better at the end.
When you're talking about a subject like cancer, it's not an embarrassment, you know, it's not a taboo subject. People hear that somebody had been suffering from cancer only when the person has died, so they don't know that they are survivors. I was diagnosed with prostate cancer in 2011, had the operation in 2012, and I'm living well since then. Symptoms that I had that go through, and I decided I have to be checked out. First, you know, I was having the feeling to pass urine very often, especially at night, and it was painful. Fortunately, since it was detected early, it was found out that it was localized, meaning that it was only in the prostate and has not spread. It's most likely for black men 45 years of age and above to have prostate cancer. There are some people who don't have these symptoms, but yet could have prostate cancer. So the key to my success was the early detection.
Prostate cancer, particularly in black men, it's a big issue. If you are scared or embarrassed to check your body out, don't be embarrassed. It's your body, it's your life. You own it. You need to make sure you do what's best for you.
For me, when my dad gets checked out for prostate cancer, it really does give me peace of mind. And just as women have to undergo screening for, like, for example, mammograms or cervical cancer, that we take our part to take care of our bodies. Just kind of encouraging that men should also take their part and take care of their bodies too.
Anne-Marie said to me, Dad, are you aware there's a profile study? It's a study finding out the incidence of prostate cancer amongst Black and Caribbean men. Some people just need the encouragement, that maybe a little gentle push to, you know, go out and, you know, look after yourself. So the reason why I decided to be part of the profile study is my dad passed away from prostate cancer 6 years ago. The way I see it is help, you know, the Black community and raise awareness about it, because I think the more you talk about it, the better it is. When you decided to go ahead with the profile study, it's a very simple process. You have a phone conversation with the staff to understand the goal, the objective, and the time that you give is like maybe 2 hours. And you go there and do the analysis, and then you get the results and full stop. That's so simple.
In my family, I have a history of cancer, but more importantly, you know, I've got young kids, and I want to obviously see them, you know, grow up, and I also want to be able to make a difference by having myself checked out and could potentially save my life down the line. So for me, really a no-brainer. Over the last sort of few years, I've been going through various sort of blood tests to check my PSA levels, and thankfully everything is fine. And it's an ongoing situation right now, and I'm very happy and proud to be part of this study.
Be tested and investigated. You know, early detection is the key.
If you're a Black man over the age of 45, you could consider discussing your risk of prostate cancer with your GP. even if you don't have any symptoms. The profile study carries out prostate cancer screening tests on Black men of African or Caribbean descent. It also looks at their genetics to see if this information can help identify those at higher risk. If you are interested, please email or call the profile study team to see if you are able to take part.
You can survive cancer. I have survived cancer.
Sorry. So those are just our contact details again. And then just if there's any questions.
Thank you very much, Jana. That was compelling. And I'm sorry, do you have more slides?
No, sorry about that.
No, that was very compelling. And the message at the end is you can survive prostate cancer, which I thought really hit the nail on the head. If you have any questions for Jana and Eva, please raise your hand, put them in the chat, put them in the YouTube or the Zoom chat, whichever platform you're on. We'd really like you to get engaged with this. What we're doing here, so let's just ask the question. Firstly, the big question has always been, why are Black men more susceptible? And no one has ever really been able to answer that. So you've mentioned a couple of genes there. Are there certain genetic profiles in Black men or men of African and Caribbean descent which makes them more susceptible to prostate cancer? Is anything in your research so far highlighting that?
So essentially, Gareth, that's what we don't know, and that's what we're trying to find out in the study. Those genes that I mentioned don't appear to be much more prevalent in people of African or African Caribbean ancestry. The BRCA gene seems to be a little bit more prevalent in people of Jewish ancestry. But the more research we're doing on genetics, the more we're actually seeing that it isn't necessarily, a risk of a cancer doesn't always come down to just one gene. It can often be small little changes along a number of genes across the genome, and that's the kind of work that we're going to be looking at. That's the kind of genetics we're looking at in the profile study. So we're hoping that we will be able to find those markers that are more associated with higher risk, and also with the higher kind of more dangerous types of prostate cancer, because like Prof. Eden mentioned, Animal, there are some gentlemen who do have a very slow growing type of prostate cancer that sometimes doesn't need any treatment at all in a gentleman's lifetime. He may just need close monitoring, like the active surveillance or watchful waiting. The work we really do want to make sure that we capture gentlemen early if they're at risk of a very aggressive type of a prostate cancer, when we have a lot of treatment options on the table.
That's key. I think that's a key message. We want to capture people early.
Yes.
In case they're at risk for an aggressive type of prostate cancer, so that we can do therapeutic interventions. I think that's the key message here.
Absolutely.
Brilliant stuff. And just briefly, because somebody may be wondering, I mean, it was clear in your presentation, but just clarify, there is no prostate examination with any of this study, is there? Because that's often an off-putting point for a lot of gentlemen.
Yes, so the DRE, or the digital rectal exam, which has been done for years and years and is very much run of the mill for us doctors. You do them day in, day out, but obviously it's a little bit uncomfortable. But we don't routinely do those as part of the research study. No, we do a blood test, and then based on that PSA, then we organise the MRI, and then that follows on then to the biopsy down the line. So your initial visit is a chat, and usually if you're happy to go ahead, then a blood test and a little urine test. And then down the line, we would arrange for the MRI scan, and then down the line again for the biopsy to happen.
It's comprehensive coverage, and hopefully we can get somewhere where we get to a standardized approach towards prostate cancer screening in the UK. Pastor Wayne, I see you had something.
No, it was just a quick question, because I saw a question in the YouTube chat. Is this limited to UK residents only?
Yes, so the study is only opened in the UK. Unfortunately, it's not international.
Okay.
Because the first appointment has to be at the Royal Marsden Hospital, either in Sutton or in Chelsea.
Of course, thank you.
And go ahead, Yana. No.
I was just going to say, so just if there's gentlemen joining that have far to travel, we do cover expenses for anybody involved in the research study. So we can go through all of that then in the telephone checks and everything.
Mm-hmm. And just to say, if anyone is interested in going, and I would really advocate, these are good people. I know some of the people they work with as well, and I can vouch for them because they are some of the people I work with also. So please, you will be looked after, you'll be looked out for. And if you're coming to, say, the Royal Marsden Chelsea site and you need someone to just go with you, I'm close by, so just get in touch with me and I'll be happy to support you with that. If I was within the age group that is recommended for this study, I would have signed up to this trial. Unfortunately, I'm just a bit lower outside of that age bracket, so I can't make it in. So I'm advocating for it is basically what I'm saying, because as was said, this will help to prevent more aggressive cancer developing and get you treated very early.
Thank you. Can I just ask one final question while we've got Dr. Jan and Dr. Eva? So questions come in. Is there a preference for radiotherapy over surgery from a prognosis efficacy perspective? Now, I know we haven't got Professor Eden or Dr. Mal, but as you're here, it's just a final question on the YouTube chat. Is there a preference over radiotherapy or surgery from a...
So my training, actually, I'm a radiotherapy doctor. That's my training. And I suppose the way Prof. Eden has a slight bias towards surgery. Often when you're talking to a radiotherapy doctor, they'll be very happy to talk to you all about the radiotherapy efficacy and side effects. But I would echo very much what Prof. Eden said is it really does depend on the gentleman himself. And certain risk factors that he may or may not have, some things like that can't be changed, like age and so forth, that might impact on which treatment option you would go for. Things like the size of the prostate may mean, and actually a particular gentleman's, the shape of his prostate can sometimes mean that you wouldn't be suitable for brachytherapy, or there'll be other things that sometimes make that decision for you. I know what we often do at the Marsden is we try and arrange for a gentleman who's been newly diagnosed to meet with both the surgeon and a radiotherapy doctor on the same day, or go from one clinic into another, so that they can discuss both options with the teams that either do the radiotherapy or perform the surgeries. For some people, actually, that can be, like Orville mentioned earlier, a bit of a information overload sometimes. So sometimes people actually choose to split up those appointments, but often it's best for somebody to come and meet both teams and have a good discussion about what the options on the table are and what's going to be the most suitable for them. And again, if you catch something, the earlier you catch it, oftentimes gentlemen will have a number of options open to them. The more advanced something is, it often will mean that some options just are gone by the time the diagnosis is made. So that's why doing something like trying to get the screening right and done early is so, so important.
Thank you so much. Thank you.
Can I ask a quick question, please?
Go ahead, Orville.
For those people that are going through it, like myself, where are the places that would be recommended for, you know, a safe space for men to talk?
I'll let you in shortly, but just to say, Orville, we're going to have a slight conversation after this.
Okay, cool.
Potentially tease out some of those areas.
All right, lovely.
I was also going to say that within our team, we have studies that are open to those who actually have a diagnosis, if they want to get involved. So our contact details are still the same. If you're diagnosed already and you want to get involved in research, there are other studies that you can get involved, as well as the screening studies for those who are healthy at the same time.
Brilliant. John and Eva, thank you so very much. I'm keen to support you and help you going forward. So we'll talk more, but brilliant study, and hopefully you'll gain some interest from the audience here today. So thank you so much again.
Thank you. I have put my contact details in the chat if anybody wants to get involved. I'll also put our generic email address for those who are diagnosed who want to get in touch with other studies.
Fantastic. Thank you. Gentlemen, we won't be very long now. Just a few more areas to highlight, including one of the things, or the thing that Orville just raised. I want to share a slide. And the reason why I'm sharing this slide with you is I think part of our advocacy is about training up our next generation of doctors and scientists. I think if anything that the COVID-19 pandemic taught us is that there aren't enough of us Black people in the medical profession, such that when we have public health emergencies in society, people who look like us are not normally at the fore of giving information, giving expertise in those areas. And I think that is a disservice to our own communities, especially as it relates to something like prostate cancer, a disease which is affecting more Black men than other groups. It is important, if we go into hospitals or GP surgeries and we have expert representatives there who are from our communities, who would understand it in the way that we would perhaps understand it, having some insights and background on those historical and cultural norms or nuances. I think it would be so good to have things like that. So one of the areas that I would like to advocate for, and I'll put up a quick slide to show this, and then we may touch on what Orville just mentioned earlier, is to build doctors and scientists from our own community who are going to help to look at this. And so I'm offering here an opportunity for any of you who may know of young people, Black young people who are bright, savvy, and probably are good at grasping technical stuff. Please point them in my direction. My email address is just there at the bottom of the screen, garrick.wilson@imperial.ac.uk. And what I'm talking about here is an area for advocacy is doctoral training in cancer technology. And when we talk about cancer, we're looking at a very strategic approach here, whereby we're looking into areas of imaging and digital pathology. So we're trying to find ways to diagnose and detect cancer very early. We're trying to develop tools that can be put into clinical practice that will be tolerable to the patients. We're trying to do implementation sciences, which is about the policy making around how these things are done, around how the government may fund prostate cancer research and treatment in the NHS and in other institutions. We're trying to develop novel technologies. So that could include technologies that is used for prostate cancer surgery, just revolutionizing that area. And we're doing discovery research as well, which may include drug discovery or medicine discovery, those new generation of treatments with less side effects that could be used to treat individuals who are faced with prostate cancer and indeed other types of cancer as well. Of course, we're very big, we're in a data-driven world, so we're big on quantitative sciences, which is about how we look at big data sets, and from that we can extract key information, look for correlations. We can also implement artificial intelligence and computer sciences to really apply these things to big topical and concerning questions in cancer and be able to do something about it. How are we doing that? This is how we're proposing to train a new generation of doctors. And this is a strategy that I particularly oversee at Imperial College London, the Institute of Cancer Research. And what we want to do is provide our future doctors and our future scientists innovative training, what we call convergence. That's the merging of engineering, physics, artificial intelligence with cancer biology to really revolutionize new technologies to detect cancer, and of course, new treatments as well to treat cancer. We really want to hear from those of you as well. That's why I thought it was so great just hearing from Orville, Paul, Pastor Wayne, Andre earlier, because the patient perspective is often better than a doctor's perspective. I think there is something worthwhile in hearing from somebody who's had to live through something as opposed to hearing from the expert, because when you've lived through it, you know something about it that the clinician or the scientist wouldn't be able to tell you about it. And of course, we want to train them in entrepreneurship. We want them to know how to spin out their own companies, how to make discoveries, and how then to go to market that. And of course, we want to also train them in human factors in healthcare. What are the bottlenecks, the barriers, I should say, that stops new technologies from coming into the NHS, which will benefit people on a larger scale? This is harnessing the power of multiple world-leading institutions. In this case, it's Imperial College London, a world top 5 university. It's the Institute of Cancer Research, a comprehensive cancer research center, and of course, the affiliated hospitals, Royal Marsden and Imperial College NHS Trust. And all of these different institutions are going to come together to train a generation of new doctors and scientists to really apply themselves in these different areas and get world-class training, which may help to reduce the burden of prostate cancer and other cancers in society. So that's my area or suggestion for advocacy. And I'll be keen to work with Jana and Ava going forward to say, if you got prostate cancer related projects that you think could fit in any of these cycles so that we can get a PhD students in, a clinical research training fellow, an MD PhD students, why not? Let's make it happen so we have more research going into this. We have money to pour into this from Cancer Research UK and other bodies as well. And we're looking to expand that that budget rather that we have to make sure that this works. And I'm very much advocating here, if there are pastors here, share this with your young people around your church. If you are here and you're in community groups and you know a lot of bright and brilliant young people there, put them in touch with me. We want more people going into the scientific and the medical profession. So that's my area for advocacy. Thank you very much for listening to me. Ava, your hand is up, and I'm going to hear your question or your thoughts.
I was going to ask that, are you directing this to those who already have a PhD, a degree that they're going on to a PhD, or are you going further back to say secondary school when they're choosing their STEM subjects? I
would love to go further back. And I think you make a good point there, because the further back we go, the more we'll have coming through the pipeline later. One of the problems that we have at the moment is if we start at the undergraduate level, there aren't that many there anyway who was interested in it at that time. So if we start in the school years, we might gain a bit more interest. But unfortunately, where we are right now, we have to start with those who are already in their degree pathway. So somebody you know who's at uni doing an undergraduate degree, maybe they're on a master's degree program in the STEM subject areas. We could then take them from there onwards. But with funding and support from other people here, I'm sure we could take this back to the grassroots all the way to school levels. Any further question? If not, I'm going to invite Pastor Wayne back into the conversation as we begin to think about more areas for advocacy. And also, Orville, you asked a really good question, and I wonder if you could jump back in and just raise your question again, please, because I think it fits well here.
Yeah, my question was, especially for men who have already had the diagnosis, may even have had their procedure, what platforms are there for these men to sit down in a safe space and talk about it? I was offered a group from my organization, but getting in touch has been a little bit problematic. The second part of my question is, whilst we're on it, is, are we thinking about going down the road of having something, and this is not to discount anyone, but sometimes having it on a church platform as well, a forum that men could get together, those who haven't, those who are thinking, and those who are going through. I just think we've started something here that I think is actually really great. And I'm just wondering, how big can we make this?
So fantastic question. I'm going to let Pastor Wayne come in, because I think there are two aspects or two parts to that question. In terms of the specific support groups, of course, you could reach out to various cancer charities who have various recommendations as to places you could be plugged into. But as you said earlier, you might be overloaded with information. It's not quite tailored, not quite specific. I think there is something, especially through the church setting, where we can have men, brothers coming together, supporting each other, being there for each other, talking about these issues from a perspective that we understand, because we speak a very common language. I think there is room for that. And I hope that's something that we can build as an area of advocacy out of this meeting today. I don't know if you would align with that, Pastor Wayne.
Yeah, absolutely. And it's probably a great opportunity actually to probably discuss the launch of initiative based around my thinking. And part of the reason this has been brought together today. As I mentioned right at the start of the conference, my brother very sadly passed away last year from prostate cancer. I was diagnosed with prostate cancer last year. So as I was going through my treatment and coming out the other side, I wonder how can I bring some positivity out of all of this negativity that's happened. And so today I want to launch an initiative called 110 Men. And the idea behind that is, or the thinking behind that was, as I said, my brother was 56, I was 54, so that equals 110. So the initiative 110 Men is basically a forum whereby as men, we can get together. And actually the 110 Men is a goal for us to get 110 men tested, whether it be PSA, whether it be MRI, whatever. I want to encourage at least 110 men, some way, shape or form, to get tested. Go and see their doctor, go and have the conversations they need to have. But it doesn't just stop there. I mean, I've set up a Facebook page, 110 Men. There'll be other events that we are going to be planning going forward, and other forums in which, as men, we can sit down and talk together and discuss some of the issues that we face from prostate cancer. So that, I think, will help to show that this isn't a one-off conference. This is something where Hope is going to build and build. An initiative 110 Men will continue to grow. We'll get more and more people involved with that. An email address, wayne@110men.co.uk, so you can certainly start to email me, because what I actually want to know when people get checked. So whether you go onto Facebook and just simply put checked, or whether you email me and say I've been checked, I don't care what forum you use. We just need to start being proactive in ensuring that men from this conference start to get checked, and we also continue the conversation. So you will be seeing this coming up a lot more in the coming weeks and months ahead. But I hope that helps to sort of share some of my thinking where we're at on this.
Yeah, that's actually brilliant. And I would love to be one of the advocates for this as well. So I'd love to join you guys in doing this, because it's really important.
Thank you very much.
Eva?
Thank you, Pastor Wayne. I was going to ask, are you going to add like a Twitter handle on that so that men can just tweet you and say that, I've been checked?
Absolutely. I will do that. By close of play today, there will be a Twitter handle up there as well, probably at 110 Men. So that will be done as well, to make sure. I want to make it as easy as possible for men to simply say they've been checked. So that will be going out as well. And I've seen a couple of questions on the YouTube about, is this available? Yes, it will be on the YouTube channel. It's been recorded. We recorded it on Zoom and also on YouTube. You can go to our NTCG Charisma channel and view this at any time. It will be up there for people to review time and time again. So it will be out there in the public domain for people to view.
I was going to add that we seem to be talking about similar things, but at different forums. So as I've spoken to Garrick, we have had similar meetings like these with PC UK. So I have put Garrick in contact with the diversity manager for PC UK so that he links into this. He's planning to do a conference with various groups around the country, and more likely it will be like a virtual meeting, so that everybody can tap into and just share ideas. So I think it will be a good idea to go forward and to flag the 110 men to be involved in that as well.
Excellent. And can I just report, I've just had my first one in, got checked. So someone got checked yesterday. So we're off. So it's 109 now. I need 109 men to verify that they've been checked, and we're off. This is exactly what this is about. Thank you.
Fantastic. And just to say with this as well, Orville, in a way as well, you've also advocated to include yourself in forming this group for men to have a safe space, a safe place to come and have conversations about what they're experiencing, what they're going through. We were sorry to hear of your experience earlier, but we don't want to leave you out there by yourself. And I think 110 men in a way is like a big hug, isn't it, Pastor Wayne?
Yes.
To say we're here for you, we're around you. And I think that's something we can support as well. Pastor Wayne, you mentioned in conversation previously about potentially bringing in MRI scanners into local communities as a way to enhance diagnosis or to get more uptake in that area. Do you mind sharing on that?
No, thank you for that. PSA is not 100% reliable at all, any way, shape or form. Had I not pushed and insisted that I get further tested by my doctor, the results I would have been totally different, I guarantee you. It's me insisting and pushing to have an MRI that meant I had a positive outcome. One of the things I'll be looking at is how can we encourage, how can we get more, how can we make MRI testing more available? Whether it's a mobile MRI testing unit, I'd love to see us being able to wheel one into an inner city and allow men to come along and get checked. Obviously, all of this, they need to have their medical records. We're not taking away from anything that their doctors are doing, but it's just making accessibility to things like MRI testing. And I believe they've developed MRI testing to the extent now whereby they can actually tell if the growth is cancerous or not. So there's already been advancements going on. And just to add as well, this isn't about me. I've gone through this. This is about my sons, Carl and Aaron. This is about my nephew Dante and my nephew Jerry. This is about the generation coming after me as well as all of my peers, to make sure that they learn from this. We learn from this. We talk about it. We encourage each other to get tested. So if we can make MRI testing more available, let's do that. So one of the things we'll be looking at is how can we then look at raising funds for MRI testing? What do we need to do that? So all of these are initiatives that we're looking to group under the 110 Men initiative. Thank you for reminding me, Dr. Garrett. Appreciate that.
No problem at all. So some great areas here potentially for advocacy. We want support group for men. I'll let you in shortly, Orville. We want support group for men. We want more men to get tested. We want MRI scanners in local communities that are accessible. In other words, they come to us, and it's not always the case of we go to them because there is a barrier there. There is potentially here as well to train up more scientists and doctors in the area of prostate cancer research that could advance what we're doing. Of course, we're hearing about the profile study as well, which we could sign up to really help to do something in this area as well. So there's 6 areas I've counted already for potential advocacy, which I think is fantastic. And I think, Orville, you're about to give us another one.
Well, it was just a thought plan. I know that the YouTube channel is running because I've been looking at it as well, which has been great. What I would probably suggest, though, is linking another YouTube channel, which is called the 110 Men, to the church platform, because not everyone's going to go to the church platform. But if you have something that is the prostate cancer awareness YouTube channel called 110 Men, believe me, you'll probably even get more traction.
Absolutely, and we will be doing that. This was obviously for the launch today, but yes, there will be, all those channels will be explored and up very, very quickly. Thank you for that.
Fantastic stuff. Well, I've got nothing more to add, Pastor. Do you?
I'm done. Listen, it's been fantastic. I just want to say a huge thank you. Huge thank you to Dr. Jana, Dr. Eva, Dr. Amal, Professor Christopher Eden, Orville, thank you so much. Paul, thank you so much. Andre, again, thank you so much.
Thank you.
And also Dr. Garrick, I have to say, he's been absolutely instrumental in this, and he wouldn't say this himself. But he's been the driving force. He's been the one pulling a lot of this together for me, all the technicals and all the professors and doctors that we've been able to get involved. He's been, words fail me. I just want to say a huge thank you, Dr. Garrick, as well. It's been really, really appreciative. Thank you. And again, thank you to everyone who's taking time out to join today. I hope you found it informative. As I said, we'll make the recordings of these widely available as possible. There'll be more information on 110 Men coming out. Wayne at 110men.co.uk. You can contact me on that. 110 Men is the Facebook page. I'll be putting information there as well. So there will be more and more information coming out. So again, thank you so much, Dr. Garrick.
Thank you. And thank you to everyone who attended, who've hung in with us. We've run over slightly by about 7 minutes, but you wouldn't have known that anyway, unless I'd said it. But really, thank you for hanging out with us. I know you're busy people and you value your weekends, especially your Saturdays, but here you are, because I know you thought that this was important. Thank you for your questions. Hope we've been able to do justice in terms of our answers to them. And also, you've received email addresses and various handles throughout this meeting. If there's anything that you go away and think about, send it through. Somebody will get back to you, because the idea here is to keep a conversation going, not to have this meeting, then it finishes, and then there's complete silence. You will hear from us again. So with that said, have a fantastic afternoon. Take care.
Thank you.
Thank you very much indeed. Bye-bye all.
Thank you.
Thank you.